So, well, velina me ke loa ia kako e nā kanaka Mauli o ka aina nui o kanaka, me nā kanaka like ole. Mahalo nā poe o Musquam, o Squamish, me Tsleil-Waututh. Mahalo ia o ko a pau no ke kipa ia mai, aloha mai, e ko kako mau kupuna kahiko e noho nei me mako pula pula. Aloha, aloha, aloha mai e nā kanaka a pau, e lohe mai I ku'u leo haa haa. E mahalo mai e Leslie no ke launa. That was a short way of saying good afternoon, everyone, in Hawaiian. But really, I was thanking you all for allowing me to be here in your space. I also recognize the three tribes that I understand are the host and the Aboriginal groups to that specific area of Vancouver, and I apologize if I got them wrong, but aloha to the Musquam, Squamish, and Tsleil-Waututh tribes or Aboriginal peoples. Also, mahalo to everyone within the sound of my voice, and I also call upon our ancestors for all of us to join us in this journey today and over this course of time while we engage in these conversations. I also mahalo the host, Vancouver Coastal Health, Aboriginal Health, for having me here as well, and mahalo to Mara and Corinne Andrews for also, I'm sure they have something to do with my presence here today. So mahalo nui kako. I want to start by, I would be remiss if I did not recognize some recent events that really underscores what we're doing here today or over the course of these 3 days and well into the future to improve our healthcare systems, in fact, to transform our healthcare systems. As we all know, and I may be saying the last name incorrectly here, but I apologize, but out of respect, I would like to just recognize what has happened recently there in your country with Joyce Eshkwan, a 37-year-old Aboriginal woman who passed away on September 28th, but not before she was subjected to much ridicule and disrespect by healthcare providers. That was actually recorded by her and shared over Facebook. It did make news, big news here in the United States, and of course in indigenous communities where we're equally outraged. But again, it underscores the importance and the need for transforming our healthcare systems into culturally safe places for indigenous peoples, but for all peoples in doing so. It also underscores the challenges and difficult work ahead of us. As my dear colleague, Dr. Dennis McDermott would often say, we need to have the hard conversations. Indeed, the conversations about racism in healthcare is hard for both indigenous and non-indigenous people, albeit for different reasons. But these are issues we need to confront and overcome together. I would also be remiss if I did not recognize the hard work all of you have already done. And here's an example of some of the work right out of First Nations in BC there around this issue. It really helps to inform us internationally on these important issues. So mahalo to all of you for doing this good work on behalf of all indigenous people and our healthcare systems across the globe. It really does inform our work, and I really do want to recognize that. And what I want to do is take a little journey in time and share with you. Obviously, I come from with a Native Hawaiian perspective, or a Pacific Islander perspective, if you will. But I suspect what I'm about to share with you would resonate very well. Very similar stories for all indigenous people across the world and things that we share in common. And one of the things we share in common as indigenous people, we come from a tradition of health and well-being. Mauli Ola, it's called in Hawaii and elsewhere in Polynesia. Mauli Ola is, to me, it's optimal health and well-being that we strive to achieve and that our ancestors actually achieved. And here I have a few quotes for you from actually the writings of Captain James Cook and his officers. David Samuel on the bottom there, his quote, he was a physician on board the expedition. When they came to Hawaii and into the Pacific in 1778, they were so impressed with the health and well-being of the native populations across the Pacific that despite some insensitive things said in their journals, they also had some remarkable things to say about indigenous people. For example, the natives of these islands are in general above middle size, well-made. They walk gracefully, run nimbly, and capable of great fatigue. They also spoke to our social temperament and how lively and of good humor we were. What they were speaking to, they came across a population that was thriving, that was healthy and well, despite the narratives that others settler societies have placed upon erroneously upon our groups. We were once healthy, thriving communities. We continue to be healthy, thriving through our resiliency. But I want to recognize this and start off with some good news, because often we talk about a lot of inequities. The other, both bad and good news, and shared among all Indigenous people, is because of contact with outsiders. We've had significant effects on our health and well-being, to start with infectious diseases that for which our ancestors had no natural immunity towards, that decimated our populations to near extinction. But through our resiliency and other efforts, we're able to rebound. And we see an increase in our populations, so much so that we actually, in Hawaii, at least with Native Hawaiians, we expect a doubling of our current population in Native Hawaiians by 2050. And as the magazine Mana here, the cover of the magazine Mana proclaims, we are a people rising. And this is excellent news for us as Native Hawaiians, but I suspect it's the same news for many Indigenous populations as we regain our culture, our lands, but also our population size that we once enjoyed, if not more. And this offers us many opportunities for self-determination going forward as Indigenous people, the more numbers we have and more influence we have in our societies. But there's also concerns if we don't change the health profiles of our communities and have transformative systemic changes in healthcare. It's just more of our people being sick much younger and dying sooner than other ethnic groups. So we do need to make some changes, and that's why we are here. And I also want to touch on some of the social and cultural determinants of health, just to set the stage for what's to come in my talk today and what I'm about to share with you. And it's similar across all groups. This is something that although the context within this figure might be a little different, certainly the ideas behind it are similar across our groups, that there are so many determinants of our health that can often is lumped together under social and cultural determinants. We have historical determinants that have influenced the current situation we find ourselves in. And they're non-modifiable. We can't change them, but we need to understand them. We need to remember them. We need to bring them into the present so that we can change the present for the future. And what is present and within our realm of control is the political and economic engines that drive inequities that we can alter. In Hawaii, we talk about self-determination. If you're not familiar, Hawaii was illegally overthrown with support by the US government, eventually occupied by the United States. Under international law, Hawaii is actually considered occupied territory, not colonized. We never gave up our sovereignty, and you'll see soon, I'll talk about two sovereign Native Hawaiian sovereigns and their start of a healthcare system here in Hawaii. But we have all these things at our disposal. We are fortunate because of our ali'i or royal legacy that we do have organizations for the betterment of Native Hawaiians around education, health, social services through their wealth and estates that remain with us in trust. There's also things within, and this is similar to all our groups, we live in environments, we tend to live in environments, unfortunately, that tend to put us at a disadvantage. We need to improve the communities in which we live. We need to improve, of course, our educational opportunities and job opportunities. But these are all things that are contributing to our determinants of health. And of course, as Indigenous people, what is very important for us is the cultural determinants of health. Those good things of our culture, and culture is only a good thing, and I'll come back to this, that really allows us to thrive and be resilient, but we need to strengthen these areas. And one of them here is cultural safety within all aspects of society for us as Indigenous people. I actually would make the argument later that we should huli or transform the system so that it is Indigenous focused or indigenize the system. We need access to our cultural institutions and practices as a people. It's part of our identity. It's part of our health and well-being. Without these things, our health is affected negatively. So we need to aspire to regain, reestablish, and revitalize these practices and institutions that make us who we are so that we can be healthy once again. Our relationship with others are very important, other cultural groups, and how we're respected or disrespected in society is important to our health. Our cultural identity and affiliations are important to us, and so is our language. And on the far right, we have what we commonly know, especially in healthcare, we're well too familiar with this, the downstream factors or the biological and psychological determinants of health. And we spend much time focusing on these areas as healthcare providers and healthcare systems. But what we need to realize that all these other domains or determinants of health really impact not just the risk or prevalence or incidence of health conditions, but also our ability to manage and prevent these conditions are really affected by these larger issues that are often viewed as outside the scope of healthcare, but I would argue they're well within our scope and they should be a focus of healthcare. And I'll share some ideas shortly. I would want to start off by saying, and remind us, what are the experiences of Indigenous peoples with the healthcare system? I mentioned, obviously, Joyce's experience there, which was the worst example of the experience. But when we ask Native Hawaiians and Pacific Islanders, and what's interesting is we set out to ask them about what are the barriers and facilitators to managing their health and being healthy? Although your typical factors that we know of, such as being access to good, healthy foods, being able to exercise on a regular basis, time commitments, stress, cost of living, all came to the surface. What was interesting and not surprising at the time, perhaps not too surprising now, this is over a decade ago, is that they couldn't help but talk about the healthcare system and their experiences with providers and staff. They talked about the distrust of providers that they have, both for historical reasons, but for also good reasons because of their experiences. They felt like there were also hidden motives or they were disingenuous with them. They even used the word guinea pigs often, that they were treated as guinea pigs. They report a lot of discrimination and maltreatment. I remember one Pacific Islander mentioning one occasion in which she went in and got her weight taken, and the staff were laughing, and she overheard them say, these people are always overweight, our scale, we have to get another scale. These are insensitive comments that are unnecessary and not unique to any one group, these issues. But they also overhear negative stereotypes and false assumptions we have to deal with. Often they face, when they're going in with pain issues, as if they're drug seeking and not getting the treatment they need. We also find that there's patient blaming, as if they really have a direct control over many of the issues that they are challenged by in managing their health. There's cultural insensitivity, negative stereotypes, implicit biases that we're learning about. One of my junior faculty is currently looking at implicit bias in healthcare among providers, and we're finding some interesting results right now that would suggest there are implicit biases towards certain ethnic racial groups, and they are Native Hawaiian and Pacific Islanders here in Hawaii that we need to address. There's often no offerings or recognition of ethnocultural or traditional healing practices that could actually benefit. Whether or not we question their efficacy in addressing chronic diseases or other issues, we cannot deny their ability, their leveraging ability to get people to treatment and as a way to complement Western treatment to ensure optimal health at the very best. People often report being very uncomfortable with the clinical settings they're in. They call that sterile, scary, uninviting. In fact, I was terribly afraid to go into a hospital up until the time I did my internship at Triple Army Medical Center, and I needed to be there pretty on a regular basis, because growing up, I only went to the hospital to say goodbye to loved ones, or I got a needle shot and it was painful. The experience often is not good, and it's not just Indigenous people; it's many people, all people, but Indigenous people in particular are saying it's not a comfortable setting. And there's rude, dismissive, and verbally abusive, and I gave some examples of this. So there are real challenges and negative experiences. And what happens to Indigenous people when the healthcare system is not culturally safe? It leads to Indigenous people and others as well to delay or avoid seeking treatment when they need it. It leads to lower rates of screening and preventive checkups, and we have numerous data on this supporting this notion. It leads to delayed treatments that are needed and detection of diseases in later stages. Here in Hawaii, many of types of cancers it's not so much that Native Hawaiians, we get it at higher rates. Some we do, but not all. It's just that we get diagnosed later, so we're more likely to die from cancer than other ethnic groups because treatment is delayed. We know we're receiving poor quality of care or sometimes inappropriate care. There's misdiagnoses, misdiagnosing schizophrenia for what we might call in our culture gifts, to ability to see things, but often giving them such a diagnosis as schizophrenia. Patient blaming, and I provided an example of that with pain management. That's very common. I'm fortunate to oversee a clinical department where we do have a behavioral health primary care clinic and work in different primary care settings. So I do get a lot of feedback from my providers and often sometimes from others, as well as medical students, what the things that they're hearing in the clinics and around them that would support these notions that I'm putting forth. Dismissing vital signs and symptoms of a pending problem or as a character flaw or stereotype of Indigenous people. I was in Adelaide in Australia for a racism in healthcare conference that I was speaking at. And I overheard, I got the fortune of hearing a white physician talking about an incident in an emergency room in one of their hospitals. It was a terrible experience. An Aboriginal man came in with all the classic signs of a pending heart attack, but the staff wrote him off as a belligerent drunk, an angry native, never gave him the attention he needed. He sat there for hours waiting for treatment. He died in that waiting room. The provider cried while he was telling this story. It's very sad. He went on to say what was even more, that was disturbing, but to continue the disrespect, he had asked someone to contact the next of kin. Half an hour afterwards, someone walked into his office and said they could not find the next of kin. Obviously, that person didn't try. He immediately looked into the phone book, took the surname, the first surname that popped up. He called. It ended up being the auntie that lived right behind the hospital. She immediately came over and claimed the body. So these are the kind of things we're talking about that our Indigenous people are facing across the world in healthcare. And because of this, it's leading to higher morbidity and mortality, and the healthcare system ends up perpetuating health inequities if we don't do something about this. It's counter to everything we uphold, to all the moral, legal, ethical obligations we have as healthcare providers. And I know that many of us, a vast majority of us, don't want this for anyone. What I want to do is share 3 organizations here in Hawaii that are moving towards strengthening cultural safety within their institutions of healthcare or medical education. But in doing so, also thriving to transform their systems by indigenizing their systems. I want to start here with the Queen's Health Systems. I start here because it's one of our largest private healthcare systems here in Hawaii, and it was founded by Queen Alma and King Kamehameha IV in 1859. It was founded through their efforts, their fundraising efforts. They literally went door to door to raise money, convinced the legislator to invest in establishing a state-of-the-art or state-of-the-science at the time clinic or hospital to address the infectious diseases that were decimating the native population at the time. They were successful, so successful that 160 years later, we still exist. The mission of Queens is to fulfill the intent of Queen Alma and King Kamehameha IV to provide in perpetuity quality healthcare service to improve the well-being of Native Hawaiians and all the people of Hawaii. What I want to underscore is the word Native Hawaiians in the mission statement. Without being in a mission statement, the commitment level is not there, but there's a commitment at Queens because of their founders. Today, it is the most advanced state-of-the-art clinic hospital system here in Hawaii with the only Level 4 trauma center in the state. They also established some time ago, back in 2007, a Native Hawaiian health program to begin to fulfill the mission towards Native Hawaiians. Their goal is to improve clinical outcomes for Native Hawaiians, increase access to their services, improve outreach to the community, provide training, not just to Native Hawaiians, but to other providers and staff, and conduct and participate in research that will help improve Native Hawaiian health. So this is a fine example of an institution that is moving towards establishing a strong foundation in cultural safety, but in fact, maybe moving in the direction of indigenizing the entire healthcare system on that journey. There's challenges on the way. Some of these challenges are the program, like most programs, and I suspect it's similar with your Indigenous or Aboriginal program, it tends to be a standalone or a offshoot of something. It tends to be a small department or program tasked with a huge task under budget to fulfill its mission. But Queens recognizes this and have increased and moved towards increasing the level of commitment and resources, but also aspiring to go beyond its 4 walls of a hospital by incorporating social and cultural determinants of health as a framework to addressing these issues and larger issues. The other organization I want to share with you, and I think it aligns with what you folks have there in Canada, and specifically in Vancouver, is a Indigenous serving healthcare system. So we have the Native Hawaiian healthcare systems, federally mandated since 1988 by the Native Hawaiian Healthcare Act. It was first enacted in 1988 with the goal of improving the health of Native Hawaiians. At the time, and unfortunately to this day, Native Hawaiians do have higher prevalence, higher risk for chronic diseases such as diabetes, heart disease, asthma, cancer, and so forth. Certain types of cancers, but are more likely to die from cancer because of late diagnoses. Because of these, for these reasons, the federal government established the Native Hawaiian Healthcare Improvement Act, which established the 5 Native Hawaiian healthcare systems across the 5 major islands. They're there in red on your screen, and the islands they're associated with. And Papaololokahi is the organization, the umbrella organization that oversees their efforts and supports their efforts and advocacy. Their task, of course, is also similar to Queen's, is to improve the health of Native Hawaiians. But they too are challenged. They're challenged because of underfunding from the federal government to really meet the needs of over 270,000 Native Hawaiians in Hawaii and an equal amount across the US. There's about 540,000 Native Hawaiians from the last census across both Hawaii and the continental US. So obviously underfunded, not big enough to truly serve its mission. To give you an example, we get roughly $39 per Native Hawaiian that's eligible for services compared to about $3,000 that American Indians, Alaska Natives get per person. So there's huge differences. And that is not even enough for Native Americans. But I make this point to say that we have an opportunity here with a Native Hawaiian healthcare system focused on Native Hawaiian health outside the 4 walls of a hospital or a clinic. And the third organization or institution that I want to talk about really is our Department of Native Hawaiian Health here at the medical school. So here at the John A. Burns School of Medicine within the University of Hawaii, we have the Department of Native Hawaiian Health. It's the only clinical department within a U.S. medical school dedicated to health of an indigenous population. And here we focus on building the next generation of Native physicians, both Hawaiian and Pacific Islanders. We do this through several strategies across the different grade levels, and I have it on there for you to see, so I won't go over them for the sake of time. But we're working to strengthening cultural responsiveness, both here in the medical school, so that we have culturally responsive and culturally safe providers that go out into our communities. But we're also working with the Native Hawaiian healthcare systems, with Queen's Health Systems, to improve their ability to culturally respond effectively to the health needs of Native Hawaiians and other Pacific Islanders. And we do tackle issues around U.S. occupation as a determinant of health, not just as a historical fact, but as a determinant of health. Social and cultural determinants, as those I presented, are highlighted with hard examples, hard clinical examples on how they actually affect ability to treat and manage a person's chronic disease within a healthcare system. Implicit, explicit biases in healthcare and their effects of racism on health in general, cultural awareness, humility, and we also talk about Hawaiian place of learning campus-wide, where it's about indigenizing our institution. But we too face many challenges here at our medical school. And I'm going to come to some of these challenges that all 3 institutions here in Hawaii are affected by. And I think it's the same for all of us across our indigenous communities working with our healthcare systems or within. I want to stop here and just ask you and just think to yourself, how are we doing currently in our healthcare systems? Do we have an integrated system, a truly integrated system of care? Is there alignment between our healthcare systems and other indigenous serving institutions tasked with improving the health of Native peoples? Are we developing and disseminating culturally responsive health promotion programs? Do we know what are the factors, biological, behavioral, social, cultural, psychosocial, that affect indigenous health? Are we producing more healthcare providers from indigenous communities or other healthcare professionals? Do we have a culturally safe healthcare system or even a medical school? And are they communicating? Now, I'll share my answers with you here in Hawaii, and I'll be quite honest. The first answer, no, we're not integrated yet, but we're working on it. There's good intentions, but there are challenges, and I'll come to that soon. Are we developing and disseminating culturally responsive health promotion programs? Yes, we're developing them. But we're stalled at the dissemination and implementation stage. There's challenges in their uptake. There's real financial challenges in getting them sustained in our communities. And there's also challenges with healthcare reimbursement around some of these because they're not recognized according to Western standards of evidence-based care. Do we better understand the biological, behavioral, all the factors that go into affecting Native Hawaiian health? We absolutely do, but not readily used to inform clinical services, public health interventions, and policies. They tend to be ignored over other priorities. Are we producing more Native Hawaiian healthcare providers? Well, we thought we did until we looked at the data more closely and found we're not increasing at the level we want and at the level needed in our communities. Do we have culturally safe healthcare systems or medical schools? No, not yet. But recent events have really pushed us with the whole anti-racism movement here in the US and elsewhere, as well as other issues. There's issues at the forefront and are being discussed, and strategies are being developed as we speak. So what's preventing us? What's keeping us to fully realizing cultural safety, actualizing cultural safety in our systems, but even more so, transforming our systems, indigenizing our systems? And I want to stop here and say, what's good for Indigenous people is good for everyone. What we aspire to do and to have is good for everyone, I think. And hopefully you'll come to see what I mean by this. And here, juxtaposing positions between what I'm calling settler safety, or the current system, and Indigenous cultural safety, what we're aspiring to and trying to achieve, and what Indigenous communities are asking for in healthcare. Settler safety versus Indigenous safety, when we look at the general, and I want to say this is a systems issue, not an individual issue. I don't want anyone to feel that any one individual is to blame or is the reason of this. It really is a systems issue that affects all of us, Native and non-Native, in different ways. But it affects all of us, and we need to really come together and talk about these hard issues and think about, what do we want? Right now, the current system seems to be more concerned with what is a matter with you or a person versus what matters to you. And this is probably a cliche by now because it's used a lot for discussing these issues, but it truly is a frame of reference or mindset on how we approach things. Are we really concerned about people and what matters to them? Or are we just trying to figure out what's the matter and just treat the illness and not the whole person? That comes into the issue of status quo versus change. This notion can be found in how we talk about issues, such as we all have the same opportunities, which is more status quo talk, compared to we are not all on equal grounds yet, which is change talk, recognizing that there is an issue that we need to fix. It is also reflected in our diversity and cultural safety programs that we develop, because they are often workarounds to policies and prevailing attitudes seeking to maintain status quo in comparison to actually changing the policies to reflect inclusion and not merely the recognition of Indigenous perspectives and peoples. Then there's the reaffirming versus affirming. Our current systems tend to just reaffirm the dominant group's historical and social position over Indigenous people versus moving to a system that affirms the history, experiences, and aspirations of others. Throughout the healthcare system, Indigenous people are bombarded with stimuli that reinforces the settler group's dominance. There are vastly more Indigenous healthcare providers and administrators and Indigenous providers than there are Indigenous providers. There's more non-Indigenous providers and administrators than Indigenous providers and administrators. Versus a healthcare environment that affirms the existence and importance of Indigenous peoples. Another thing I often hear that seems to come up a lot in conversation is kind of this issue of the past is the past versus for Indigenous people, the past is present. I often hear and get asked, why are Indigenous people so focused on the past? Shouldn't they focus on the future? Well, of course we do. This is a misperception and at the same time, a difference in the perception of time. You see, Native people walk into the future with their eyes on the past because they are guided by their teachings of their ancestors and believe we need to know where we have been to inform how we proceed into the future. The past, the present, and the future are all operating simultaneously for Native people. We think about the consequences of our actions and behaviors today, 7 generations into the future. It also reflects the hurt we experience in the present because of the historical trauma we have experienced as a people. The negative political, physical, psychological, and social consequences of this traumatic past are affecting our health and well-being in the present. So yes, the past is always present, whether we want it to be or not. We need to start looking at doing away with defining the experiences of others based on our own experiences and recognizing the experience of others. I have been in spaces such as meetings where I am the only native Hawaiian in the room. A person asks about Hawaiian culture or people to the group, and the first to respond, and often quickly, is the non-Hawaiian in the room. Defining our culture for ourselves, rather recognizing our diverse experiences. I am currently consulting with a professional organization. I won't mention what organization this is, but they are a healthcare related organization that are having some issues with their members. There are some members who are seeking to define diversity from their perspectives. You see, when others define other people's experience, they often define it based on their comfort level and based on their preconceived notions and biases of the groups. Our groups, our people need to define and define our existence ourselves, and our own aspirations need to be put forth and not have others define or be based on what others are comfortable with and what is allowable to others. The current system seems to be focused on individual rights and autonomy in healthcare and making health changes versus our indigenous notions of obligations to others and collective aspirations. And some examples of this is the idea in healthcare, we focus too often on the individual and believe that the changes a person needs to make to prevent and manage their illness is entirely under their control. But the truth of the matter is that many factors influence our health and well-being, whether indigenous or not, that are outside our direct and immediate control. Take the effects of education and income on a person's ability to eat healthy and get regular exercise. The role of stress on memory and how that gets in the way of people remembering to take their medication. The competing demands on a person trying to make ends meet and feed their family. The complications of poorly managed diabetes is not on their minds in the here and now, indigenous or not. We need to shift our mindsets, our focus into a more indigenous perspective of healthcare. Intimacy hinders objectivity is often what we learn as health professionals. As a scientist, I've been told that be objective, don't let your emotions get in the way, it biases your results. But we learn that trust enables healing for indigenous people. And we learned that there is a mistrust, and that is affecting their ability to heal or be healed. So we need to start working to a system that moves away from the notions of objectivity to the notion of trust, and then that its effects on healing. We tend to overlook differences in our programs. Again, it's a systemic issue, not an individual issue. A lot of our things we do tend to be a one-size-fits-all kind of approach. We adopt evidence-based strategies or guidelines, but much of the evidence were garnered based on dominant group samples. So how effective are they with other groups and indigenous people? We need to start respecting differences and respect that one size does not fit all. And there are multiple ways to health and healing, multiple perspectives and multiple aspirations in this regard. There's also a lot of defeating narratives in our healthcare system. I cannot tell you how much I shadowed, been around, overheard, or been told about insensitive, erroneous information, and just opposite of what we're taught in medicine to be objective, to be evidence-based. I've heard things, I've been in a room with a physician treating a Native Hawaiian woman with diabetes, for example. And she asked him, "Doc, why do I have diabetes? And by the way, my parents had diabetes." He responded by saying, "Well, you're Native Hawaiian, and so you're at risk." Well, we know that's not true. There's non-Native Hawaiians, non-Indigenous, there's white people with diabetes. There's other risk factors. Just unfortunately, those risk factors are higher in our populations because of disparity, inequities, and other reasons. But they're not Native Hawaiian, the ethnicity is not the reason. But what we're telling patients though is, the reason you have diabetes is beyond your control, is something that you can't change. Therefore, your ability to manage it is not within your control. We need to have empowering narratives in our systems. We need to empower people to change and move away from these misinformation. I realized the doctor was just taking a shortcut in explaining things, but it has a damaging effect on our Indigenous people in managing their health. So to end this particular slide here is we need to move away from modifying our systems, which I think right now, to be honest, cultural competency, cultural humility training, even cultural safety, although a step in a good direction beyond simply cultural competency is much needed, it's still a modification to a broken system. What I would say is that we as Indigenous people want a transformed system. What does that look like for us? I want to share a quote by Dr. Elijah Anderson, an African-American sociologist. White people typically avoid Black, in this case brown space, but Black people are required to navigate the white space as a condition of their existence. This is a reality for us as people of color, as Indigenous people, is that we have to operate in someone else's, another group's, a dominant group space. We always have to be mindful of our position, which creates a lot of tension and issues for us. We need to move away from this and make all people, Indigenous or not, feel comfortable in our spaces, especially in our healthcare system, where we are designed to help others. Right now, currently, the status quo is there's often, and not always, and I don't mean this as a reflection of your organization or any other organization, but in general, a lot of the Indigenous approaches tend to be superficial. There's a superficial inclusion or representation of native language, artifacts, and images, more as decor. And I consider this more of a shallow approach. But we want to transform that into a genuine inclusion of native values, concepts, and practices in the physical environment, social and spiritual spaces of our healthcare systems. So you have a more authentic experience and care for our people, for all people. Indigenous roles are often relegated to cultural protocols and ceremonies or advisory roles in our systems. I cannot tell you how much I get more requests to open a conference with a Native Hawaiian cultural protocol or blessing than I do to give a keynote. That needs to change. I've heard similar things from my colleagues who are working in Native Hawaiian programs within healthcare systems. They do more around the superficial things than the real deep issues, the authentic issues that we need to be doing. So we need to move to Indigenous persons, perspectives, inputs included in governance. Do we have board members who are Indigenous, not community advisors? I'm saying board members with ability to guide the institution. Executive decision-making. Do we have Indigenous executives in our ranks? Our practices and policies, do they reflect Indigenous values, perspectives? That's what a transformed healthcare system is about. Indigenous programs, services are standalone, right, for the most part, or even siloed. They're small programs, underfunded to do a big task, and they're often not embedded within the healthcare system itself, across the healthcare system. But we need to move to Indigenous program services deeply embedded across all service lines, all departments, all aspects of our healthcare systems, so that it's truly integrated, not marginalized. Evidence-based treatments. We tend to focus on illness. We need to move to focusing on the whole person, on wellness. We need to look at culturally responsive guidelines, interventions, and policies. Right now, status quo, the number of Indigenous healthcare providers do not reflect the population. There's inequities. We do not have enough healthcare providers who are Indigenous or even other health staff members within our systems. We need to move towards equity in healthcare, even among our healthcare workforce. That's a transformation. That's a balance. That's equity. Finally, the Indigenous patients, right now, from what we know, they try to avoid or delay seeking treatment from our systems because they don't feel safe or trusted. Often, despite having Native Hawaiian or Indigenous health programs present, we need to work towards making them feel welcome, safe, and trusting their providers within our system. I know my time, 1 minute. This is my last slide. I want to end with this. I think Dr. Paparangi Reid from Aotearoa, New Zealand might be a keynote tomorrow. And she's a co-author on this paper. This paper is actually co-authored, or these consensus statements, that I'm sharing with you, these principles were co-authored by healthcare educators, providers across Australia, New Zealand, Hawaii, and I believe even Canada is represented among the authorship. But they put forth 6 principles. They really put forth these principles in the context of medical education, but I think it's also relevant for our healthcare systems as well. And that is colonization is a fundamental determinant of Indigenous health, and that needs to be understood. Here they say medical education, but I would also add healthcare institutions must have a framework for understanding and addressing racism and privilege at institutional and curricular levels. Our institutions need to explicitly address and develop Indigenous health curriculum or even healthcare strategies with rigor defined both by Western and Indigenous standards. We need to move towards incorporating Indigenous concepts and principles, and they need to have them reflected at all levels in policies and practices, but also in the staff, the providers of our institutions. Advocacy for Indigenous rights and Indigenous health development. A healthcare system has great influence in society, and it needs to leverage that influence to improve the health of everyone in the society. And right now, the Indigenous communities need your voice. Institutions must invest in this infrastructure at the level needed to properly and effectively address the mission at hand. It needs Indigenous leadership, and it needs to be well-resourced. And I conclude with that, and I say mahalo to all of you. And I ask, I'll just leave you with one charge: to go beyond cultural safety, but let it be the catalyst for transforming our healthcare systems and indigenizing. Because I think what is good for Indigenous people will be good for all. Mahalo.
Wow, just amazing. Mahalo. Amazing presentation. You definitely speak our language. We share all the similar disparities in healthcare. Great slides. I love the one with the settler. What did it say now? What did you call it? Settler safety.
Yeah.
That really creates a bit of a mind shift, and the way you presented it was amazing.
Thank you. And a bit is a bit provocative. And again, I don't mean it to reflect any individual or any intent. It's just a system. It's an issue. It's an issue that has developed over time. And unfortunately, both settler and non-settler, Indigenous and non-Indigenous, we're all caught up in this. Yeah.
I think, well, the principles alone, as you mentioned, you know, it's our social and cultural safety and those determinants, the social determinants, but we have cultural determinants of our health and well-being. You mentioned Paparangi Reed. We tried to get her. Unfortunately, we couldn't get her, but she is on our list of future. We've had the good fortune of having a video clip of her that we use in some of our training. And she's quoted in there, we say it often, is that this global Indigenous health inequity, we're all the same. And she just states, yes, we're all the same. We all have the same health disparities. The horror of that is that it continues.
Yes.
I mean, just, you know, and you made a statement, something along those lines as well. It's just, how can we continue with this devastating data? Actually, Cindy Blackstock used that this morning. This devastating data,
It is devastating.
you know.
It's unnecessary. And it's modifiable.
Yeah.
It's really modifiable, changeable. Yeah.
This is what we're all trying to do, and all of the participants that are joining us here today, and for, you know, yesterday and many other days, we've actually had thousands of our Vancouver Coastal Health staff join us for Indigenous cultural safety training, to become allies, to learn, to do better. You mentioned a lot of that in your talk about, come on board with us, don't do for us, be with us, let us help lead the way. And I can honestly say that we are getting to that very successfully now. There's been lots of questions in the chat box. Clearly people really like your provocative thinking there around that one slide that maybe you could actually, since you're still sharing your screen, if you could bring that one back up. That one, this one is so good, the way you speak about, no, we're not looking for modifying the system. right? We don't
Right.
need it sprinkled with a little bit of Indigenous.
Indigenous flavor.
Uh, yeah, yeah. No, we want it actually hardwired, and that's the term we've used here in BC, in particular Vancouver Coastal Health. We use a system transformation approach, a very business approach around. We don't want you to just, create another Aboriginal specific program or service. We want to change the existing services that you provide to make sure that there is an inclusion of the Indigenous population within your thinking and spending, quite honestly. The talk earlier was about creating Indigenous culturally safe spaces, because we can do that with bricks and mortar as well. So I really loved what you said about transforming systems. It
Wow.
is different than modifying.
In Hawaiian, the word we would use for transforming would be hulihia. And hulihia means just turning it upside down and just letting it go and then starting over sometimes.
Yeah.
Sometimes. But,
Sometimes, all the time. How about all the time?
I think
Yeah.
a lot of all of our systems, our largest systems, are broken, and I think it's broken for even white populations. Here in the U.S., I always say, being American is bad for your health, even for white people.
Yeah.
Although in the U.S. they have better health outcomes and longevity, but compared to European counterparts, they
Yes.
have more heart disease and die sooner than others. So it's not, something's not working for all, and
Yeah.
there needs to be a cultural shift. There needs to be a shift, a transformation across our systems, and we're learning that with COVID-19. Pre-existing inequities have only led to inequities in COVID-19 experience and even risk. So things need to change.
Absolutely. We have also embarked in that in Vancouver Coastal Health with our diversity, equity, and inclusion. And one of my colleagues has said that very clearly. What COVID has done is actually just amplified for us the disparities and the need to make sure that we're serving the most marginalized in our populations. So excellent. I loved also where you said the past is the past. Again, settlers saying, why don't we just get over it? It's because it hasn't stopped. Quite honestly, we're saying it actually hasn't stopped. And yes, the past is a present, but we also have in the same kind of cultural world values as Hawaiians, is the 7 generations before and 7 generations after, right? So we're always looking back and learning from our elders and our ancestors. I'm going to try and get to some of these questions, and I hope you can stay a little longer. We actually have a few more minutes that we're taking of the next group, because we can, and your talk is so engaging. If you don't mind, we could take up to about 2:08. Thank you so much.
For a while more.
Awesome. One question that came in, do you have any suggestions to other institutions for developing their own equivalent Department of Health to create a department to decolonize the medical instruction from within?
That's a great question.
Yeah. Wow.
I would love to see clinical departments in all medical schools focus on Indigenous health and the health of their most marginalized groups in general. Because although our direct mission is towards Native Hawaiians, we do include other Pacific Islanders and even Filipinos here in Hawaii, because we share similar health status and similar values around addressing them as well. But we're fortunate as a department to be this is why I talk about budget and making sure we put monies to things, because the way we were established by the university was an investment made by the Queen's Health Systems. Queens gave the university $5 million to start our department and to match, and to ask the university to match in starting the department back in 2002. If it was not for Queen's investment, I'll be honest with you, I don't think we would exist. Imagine that. It was a radical idea for its time. Because we're not, in medicine, you got to understand, clinical departments, you're either pediatrics, you're either family medicine, geriatrics, surgery. We're not a specialty of medicine. We're applying medicine and public health and other strategies to a population. So we're very unique in that regard. So it was radical at the time. And to the dean, Ed Cadman, who was a dean at the time, who had the foresight to say, let's do it, who garnered the resources, to Dr. Nalin Andrade, who's a native Hawaiian, former chair of psychiatry here, but was chair of the board at the time at Queens, and Art Ushijima, who was the CEO, who said, let's do it. Let's create a whole department around this. That's how we started. We got started through a private and public partnership. And what I would say is, look to your other entities in your area to see what you can do and leverage and bring together. But what I can tell you, and I'd be more than happy to, if you want to email me to assist, is we have, talk about return on investment.
Yeah.
We are a very successful department because of our unique focus. We've doubled the monies, or we bring in more monies that have been able to sustain us through federal grants to do good research with our communities as co-investigators. We've been able to leverage educational grants. We've been able to garner more funding from private organizations who are buying into our mission.
Amazing. Yeah, money does help for sure, and resourcing. And you did mention sometimes the Aboriginal health departments like ourselves, Aboriginal Indigenous health resources are sometimes an afterthought or whatever. I'm happy to say we just got some new funding, which is fantastic.
Awesome.
We've been working at this for a long time. I think you mentioned an understanding of BC and First Nations and the formation of First Nations Health Authority, and the mobilization of First Nation voices in actually determining their health and programming. And you mentioned in the governance, not just on advisory committees, but on boards. So we have 2 Indigenous strong women from 2 of our First Nations communities here within VC region. Yeah, Chief Marilyn Slett from the Heiltsuk Nation, and newly Deborah Baker, who's a council member, but also now our board member from the Squamish Nation. So it is absolutely important that we have representation at a decision-making level, and that's really thanks to our board chair, Dr. Penny Ballum, who's been very active in championing all of that and ensuring that the Indigenous lens is applied throughout the organization. One of the things that came up too, and a couple different questions around cultural safety and that language around cultural safety, which you've used, but you also said we can use this in different ways as well. Here we're asked about, and actually I just received this question just last night and I had to ponder it a little bit. I haven't answered it yet. I was asked, do we want to use cultural competency within a mandate statement or a vision statement that we have culturally competent organization? I really have always kind of steered clear of the word competent and competency. And I'm wondering what your thoughts are around the cultural humility, cultural competency.
Well, I too never like the word too much, cultural competency, for many reasons, and probably the same reasons all of you are hesitant in using it. And when the idea of, when it came out of New Zealand through nurses, right, Indigenous nurses, Mauli nurses, the idea of cultural safety just takes it to another level. It wasn't just about developing some knowledge, basic knowledge, in fact, I actually taught cultural competency for a while at the graduate level, which I just didn't like. And of course, I injected my thoughts and other ways of thinking to that course, but I had to follow the objectives of the course. But it really takes it to another level, cultural safety. It also asks you as a provider to understand the relationship, power differential between you and the person you're treating, and recognizing that and addressing that. So it takes a lot of what cultural competency, I think, was just real, again, superficial, surface level. It was a check the box to me a lot of times. We got that. And to have someone totally competent in someone else's, that's also insulting at the same time, right? So I think the cultural humility notion was a way around that, right? Where, well, you're not going to be competent, but could you have more humility around this, right? So it was a journey on towards a better place. And then now we're on this journey towards cultural safety, or in cultural safety. And I do like it a lot. We're actually promoting it here. And we're working on some curriculum and other things around that. But what I find challenging around whether we're talking cultural competency, humility, and cultural safety is when we do this line of work, what I find challenging and that we need to do, and I don't find it challenging. What I see is it lacking, but it's not challenging because we can do it, is connecting the dot for folks. Because often when we're training, we're talking about these things, unless you can connect the dot between a cultural concept, behavior, preference, with how that might look in a clinic setting, you as a provider, how it operates. When I talk about social determinants of health, I'm not just talking just about what happens in politics or in the community, but how does it operate with that patient, with your medical recommendations when they make, and their ability to carry it out after they leave your office. And I try to give hard examples. Because without hard examples, people want to do this. It's hard to internalize and really operationalize the things we're asking people to do if we don't give them hard examples that they can relate to.
Absolutely, absolutely, totally agree. And I am actually sticking with the language of cultural safety because it embodies all of that. It embodies programs and services, so that clinical safety from the patient to the provider, safety around spaces and places.
Yeah, yes.
It just really,
cultural competence didn't really do. Right.
Well, and I don't think that you can be that bold as to state that your organization can be competent. That was just such a big, bold statement. I think it's a very personal measure of competency.
Yes.
Institutional measure, not so much. Somebody else just...
medical competency, there's variations in that, right?
Yes, yes.
Right.
Competency around skill sets, yes. One of the other things that mentioned in the chat box there, and that I made note of, you mentioned how a physician said to a patient something about, oh yeah, you're kind of predisposed, you're going to get diabetes. And I often think that because that messaging has come across so frequently for Indigenous people, we actually, I noticed this several years ago with a group of my own fellow people saying, their discussions around the table were more about, oh, do you have it yet? Or you're going to get it, almost like we're all going to get it. Did you get it yet?
Yeah, no, it's the same here. Because the messaging they've gotten from the outside is that you're going to get it because you're Native, which is not true. And if we go back to when Cook first came, he couldn't find disease.
No.
Exactly. Now is about 50% or so for us as Native Hawaiians. You recall what he said, right? The average Hawaiian ran gracefully, capable of great fatigue. So we're not destined for these things, and we need to change the way we're talking. We need to empower people for change, not defeat them.
Yes, I totally agree. I see our board chair, Penny Ballum, has also put a question in the chat box around identity and collecting identity, about what do you have as experience around encouraging Indigenous patients, Native Hawaiians to self-identify as Indigenous. I don't think you have the same status card in this number attached to you as a Native Hawaiian as we do here in Canada, which has always been the default of, oh, your identity is tied to this status number. Yeah. Other than that, you have to self-identify. So she's asking, what has your experience been on helping to kind of, well, one, we need the data. You mentioned earlier, evidence. Without the data, we have no evidence, so we don't show up in the evidence. So what's your solution around that?
No, we are working on this as we speak, and COVID-19 really brought to light the issues we have around data collection, especially around ethnicity and cultural identification. So even our healthcare systems. And as you know, most Indigenous people, because we've been, in the system, experiencing others for so long and so open to intermarriage, a lot of us are of mixed ancestry, at least, right? And here in Hawaii, some people report having Native Hawaiians, Filipino, and Caucasian. What we tend to do here is collect all the primary ethnic or racial groups, right? And then what I usually do, I ask the question of your ethnic groups that you identify with, of your ancestry, which one do you most identify with? Which one do you most identify with? Which gets a sense, because there are Native folks and there are others. There's immigrants that have assimilated, and it's totally fine. It's okay. But our research actually shows that 94% of Hawaiians, despite their ethnic admixture, strongly identify with being Native Hawaiian. So I think it's important to both identify their ethnic identification, but also the degree, because that does inform, it helps, at least clinically too, sometimes it helps us understand where they are with things, right? What approaches might be acceptable? What things can we explore? What to expect? I don't know if that answers your question, but across the board, data is important. The more granular we can get, the better we can get at understanding what works within our groups better, because there are within group variations. And that kind of data does help us to understand between group differences, but also to understand within group differences.
Yes, no, and we've just brought on our very own and our very first Dr. Brittany Bingham as our Indigenous Health Research Director.
Yes.
I think you might have come across Brittany before. So exciting, and she often talks about, and she's also doing some COVID research with the urban Aboriginal population, often talks about, people have lots of data, all the academics who have researched in the downtown east side, like for decades, there's data, reams and reams of data about Indigenous people, but unless you have an Indigenous person on your team, the research team, or if you don't have the approval under OCAP to actually look at that data, it goes unspoken about. It doesn't get reported, and nobody is able to actually go through there and say, oh, this is a story that we're learning through that evidence. So we hope to change that. We've been doing a lot of work in that area, so thank you for that. But I guess back to that identifier, we have a system here called CST, and Clinical System Transformation. It's an electronic medical record, and there's an opportunity to capture that ethnicity data in there, and that's what we're trying to do. Do you have a similar kind of, is it a global database?
Most of our hospitals use what we call, it's called EPIC. It's their electronic health records. But a lot, they're highly, you can adjust and modify these systems to collect the data you need. And and there are social determinants of health modules, and not all the systems use them. But if we're to start to incorporate them into data collection, into the records, we can begin to get more robust data to begin to look at how does these determinants of health affect what's happening in our clinics to our people. So I've been encouraging some of the hospital systems here, is not all of them use that module. And so there's other reasons to why they're not using it, of course, expense and complications and IT issues and so forth. But they're beginning to consider that and begin to say, yeah, it's important. So that's a step in the right direction for us.
That's incredible. And one of the other major considerations that you mentioned about the workforce, right? So the recruitment and retention of Hawaiian natives to health careers, or attracting them in health careers early on, maybe in high school, whatever it may be. We often notice as well what we're trying to address here in BC and Vancouver Coastal Health is that idea of knowledge, right? We often look for a degree in something, a master's in something, a PhD, and we want to move away from always kind of privileging that academia to cultural knowledge. Have you been able to make any shifts around that yet?
We have some legislation around that ability to, we have kupuna councils, for example, that oversee our Native Hawaiian healthcare systems. Kupuna is the word for elders. A lot of it has to do with traditional healing practices, but it's not true. It's not really that integrated or available or accessible right now. We still have challenges to that. Part of that is we want to respect our traditional healers and their profession and how they want to engage and interact with the healthcare profession. I think there's a shift, though. I think, if you go back 20 years, there was probably a resistance by Western medicine on traditional practices, right? But I think now, at least the physicians and other healthcare providers I talk to, they say, my patients are asking for it. Where can I get it? Where can I refer them to? So we need to kind of create a better a way for that to happen. But I think we're not quite there yet. There are some good examples. We have a Waianae Coast Comprehensive Health Center, which is one of our federally qualified health centers in the most populated or densely populated Hawaiian community in Waianae, who I believe have an on-site traditional healers that they can be referred to and interact with. So, you know, we're getting there, but we have a lot more work to do. And as you know, we're not, unlike American Indians, Alaska Natives, we don't have that kind of recognition by our federal government. So we're not under the Indigenous health services. We have a different line of interaction with them, which is often difficult. So that makes other things challenging for us to really initiate or get going. We also, going back to data, we also are lumped under with other Pacific Islanders, and as you know, the strategy here is also to lump us with Asian populations in reporting out data because of small sample sizes, but they actually mask our true health inequities.
Wonderful. That's just amazing. We have so much in common. Your kapunas are elders. We actually have a major milestone here in the province of British Columbia where the Ministry of Health has just funded our primary care networks, and that's meant to kind of help us to have that kind of team-based care under one roof, but not just co-located, but actually collaborative care. It's easy to put everybody under the same roof, but this is meant to help them be very collaborative in the care model and team-based care, which now includes elders as
Nice.
part of the care team at the primary care level. Is just amazing. And just like you mentioned, our Indigenous population, yes, they get to see the elders, but our non-Indigenous staff also benefit from the elders being present in the clinic. And they'll say, can we see the elder too? It's like, absolutely you can. It's part of the healing for everybody. We share, we're generous with our knowledge.
Yeah. It's to my point that what is wanted by Indigenous people is also what others are wanting, because whatever what we have in place is not working for everyone. Right?
Correct.
What we have to offer is a gift. I always say, Indigenous people, we're no longer, we're no longer islands. We're so interconnected that you just can't simply go to another place when your resources are run out, or the world is an island now. And who better has those kind of knowledge systems to live in harmony, to preserve your resources and make the most of it than Indigenous people. We maintain those things.
Absolutely.
So I think
well, mahalo, Haichka, Osiam, thank you so much for spending this time with us. I'm so sorry that we ran out of time. I could talk to you for hours. We have so much in common, and experiences, ideas, things to look forward to in the future. As soon as we're allowed to travel, I certainly hope that I can come back to Hawaii, my favorite place on earth. Again, thank you so much. I hope that we can share the slides, especially the one in front of us right now. Settler safety, Indigenous cultural safety. Thank you so much for sharing your experiences with us. We so appreciate your time.
Mahalo ya oko.